Good evening, everybody, and welcome to the National Fellows Online Lecture Series. Uh, this is a joint venture co-sponsored by the Fellows Online Education Subcommittee, the Education Committee, and the Fellowship Committee within AMSSM. My name is Dr. James Robinson. I'm your host tonight. I'm a sports medicine physician at Hospital for Special Surgery in New York City, and I serve as the team physician for the WNBA's New York Liberty. The goals of this program are to supplement your home program's educational content, and we want to provide fellows with direct access to educational experiences with AMSSM members and at times invited guest speakers. And the main goal is to help and assist in CAQ exam preparation. So just a few housekeeping things. If you'll mute your microphone and turn off your video to allow for optimal function of the Zoom. If you have questions, submit them through the chat function. We encourage questions and we will have time for questions at the end. And then at the end, there will be a link to the evaluation for the lecture. If you'll please complete that, that helps us for coming up with future content. We want your input. So if you have topic or speaker suggestions through the AMSSM website, if you go to the National Fellows Online Lecture Series, there's an option there to submit topics for suggestion. Remember, these are CAQ type topics, or if you're more technologically advanced, you can just scan the QR code that goes directly there. So without further ado, it's my honor tonight to welcome Dr. Nathaniel Nye, who is a sports medicine physician at Intermountain Health Center in Cedar City, Utah, where he is the team physician for Southern Utah University. He recently separated from the Air Force after 13 years of active duty service. During his time in the military, he served as the assistant program director for the National Capital Consortium's Sports Medicine Fellowship at Fort Belvoir Community Hospital in Virginia. And he is was an associate professor of family medicine in the Uniformed Service University Health Sites at Bethesda, Maryland. Prior to that assignment, he served 5 years as a sports medicine physician, supporting Air Force basic military training. And there he developed from the ground up a sports medicine network consisting of over 35 sports medicine professionals working in 10 embedded sports medicine clinics, supporting the basic military training enterprise. He and his team demonstrated large positive fiscal impact via a 3-year, 980,000 grant-funded study, which has since been published. And he currently serves on the AMSSM board of directors and the chair for the Sports Ultrasound Committee. And today he's going to talk to us about rhabdomyolysis, both the diagnosis, treatment, and return to play considerations.
Hello. Thank you for the invite, the opportunity to talk here. This is an awesome lecture series. I myself have referred to it many times in preparing for my board's exams, which I recently retook. And it's been very valuable to me. So it's an honor and privilege to be able to talk to this audience of my friends and colleagues around the country and perhaps even beyond that, about a topic that I'm passionate about. And I consider myself fortunate to have trained in a program that really was strong in this area. So I'll talk more about that. So for tonight, we're going to go over exertional rhabdomyolysis and current concepts for diagnosis and evaluation, as well as treatment and return to play. I do not want to go any further without acknowledging several people. First and foremost, Dr. Fran O'Connor, who was one of my faculty and really is the leader of sports medicine in the military, and has done an incredible amount of work in the field of exertional rhabdo and other exertion-related injuries, and has shared his passion with me and all of the other fellows who have come through that lineage of the military there in the DC area. So I will forever be indebted to him for that, and giving me opportunities as well. Him and Anthony Butler putting me in positions in the military to go ahead and tackle problems like this. Dr. Randy Eichner deserves mention as well. Some of you may know he is a founder of AMSSM and has done an incredible amount of work in the field of sports medicine as well, and exertional rhabdo as well. You'll find his name if you are searching the literature for exertional rhabdo. You will come across many publications by him. He's an emeritus professor at the University of Oklahoma and really has done a tremendous, I mean, just absolutely unbelievable job of just being on top of the epidemiology and understanding where the cases are coming from and what is causing them. And so Dr. Leggett, Jeff Leggett, is also another military doc, runs a multidisciplinary case review committee there in the DC area and reviews all the complex cases of rhabdo that come in from across the military. And Dr. Patty Doister is just a phenomenal mind, a researcher. She's actually a dietitian, and but is a brilliant mind and has done tons of writing and research and publishing on this field. So there's a lot of more people, but I think these four deserve special, recognition as thought leaders in this field, and I certainly draw from them in in sharing this presentation. So there are two papers that I would refer you to, and a lot of the content from this presentation comes from these two papers. The one on the left is a clinical practice guideline that was developed by Dr. O'Connor and Dr. Doister, Dr. Leggett, and a bunch of other more junior sports medicine and other doctors. So really, that is the backbone of the content. And there's several key algorithms that I will be presenting. We later, Dr. O'Connor gave me the opportunity to kind of rework this into a civilian manuscript that was then published in CSMR. And that's what you see on the right, which is just basically a reworking of the same document. But we'll be referring to these, and I would recommend that you read them. Okay, so Andy, this is my first question. I would like to have each of you answer the following. So you'll see the bubble pop up. Which of the following athletes has exertional rhabdomyolysis? A, an 18-year-old female distance runner who has severe pain and stiffness in her quadriceps bilaterally 24 hours after a race. She has a CK of 16,000. How about B, a 23-year-old male Army recruit with mild to moderate soreness of his triceps. He's been doing lots of push-ups. Otherwise asymptomatic. CK is 35,000. C, a 25-year-old female triathlete who nearly passed out at the finish line, was given IV fluids in the medical tent, was sent to the ER with generalized muscle weakness. They checked her labs. Her sodium was 152. CK was 2,800. D, a 21-year-old male gymnast with dark brown urine after an intense workout. UA was positive for blood and showed 3+ RBCs, and there was debris on the microscopy. Or E, all of the above. And let's see, I minimized the bubble so I could read it. Hopefully everybody's had an opportunity to answer. Andy, are you able to display the results of that?
Yeah, we'll give it another about 10 seconds if that's okay for people to jump in, and then I'll share the results.
Sounds good. Okay. All right, we have a lot of people answering with E, and we'll talk about that. It is possible, but actually, the right answer is A. And I worded this question intentionally to kind of catch you on a lot of common misconceptions. So we are going to talk about this as we go along through the presentation, and you will see as we go through why it is A. But let me just say briefly, the reason it is A is because exertional rhabdo is a clinical diagnosis that requires symptoms and signs as well as laboratory features, including a CK greater than 5 times the upper limit of normal. So athlete A is the only one that meets that criterion. B has the labs, but not the clinical findings that we would expect. Mild to moderate soreness does not qualify to meet a diagnosis of exertional rhabdo. C, the CK value is high enough, but generalized muscle weakness. This athlete may go on to develop rhabdo. this question is written such that this athlete is less than 24 hours from the onset, and generally the signs and symptoms of rhabdo develop within the first 24 to 48 hours. A lot of times people don't present into the clinic or the ER until 24, even 72 hours later. So this athlete does not have criteria. They have generalized weakness. Maybe there's rhabdo, but we don't have enough to really make a diagnosis there. And D, this athlete does have dark urine, which is often seen in rhabdo. But the key is with rhabdo, you will have a UA that's positive for blood, but there will be no RBCs on the urine. So we'll talk more about that as we go along. Okay, so that's valuable. I hope that this is a key question, and I want you to remember that principle. It's a clinical diagnosis, not just a lab. Okay, can we go on to the next slide? For some reason, here we go. Okay, question number 2. This is intended to be a little bit challenging as well. Acute kidney injury is common in cases of exertional rhabdomyolysis because of which of the following reasons? A, myoglobin sludges in the renal tubules, or B, creatine kinase is later converted to creatinine, which leads to the elevated serum creatinine, which we see in AKI, acute kidney injury. Or C, creatine kinase is toxic to the kidney and impairs urine concentrating ability. D, these athletes typically have a pre-renal AKI due to dehydration combined with inability to compensate due to hyperthermia. We'll give you time to think about that and then chime in with your answer. Again, both of these questions are centered around common misconceptions, and I hope to clear them up for you. All right. Okay, I didn't trip you up this time. 82% of you are correct who chose A. So good work. Myoglobin does sludge in the kidney, in the tubules, and that is the toxicity that often leads to acute kidney injury for rhabdomyolysis patients. It is not the CK itself, and CK is just a marker. It is not toxic to the kidney. And although they may be pre-renal, they may be dehydrated, they often are, that is not the primary reason why we are concerned about the kidneys in patients with rhabdo. Okay, let's dive in. Hopefully you've got your juices flowing. We're going to talk about some epidemiology. Then we'll go into the pathophysiology. Hopefully, I find it interesting. I'm going to try to not put you to sleep on this stuff. In the general population, we see 1 to 2 cases per 100,000 person years. This is uncommon. So certainly within sports and athletes, you're going to see it much higher incidence depending on the athlete. In the military, we see about 40 per 100,000 person years. It's about the same in civilian athletes, probably. Depends on the sport. Certain sports such as football, particularly fall football, and CrossFit as well as ultramarathon are kind of notorious, although whether that's merit warranted or not, I've certainly open to debate. I think that anyone doing any type of intense weightlifting is susceptible to rhabdo, especially if they're taking supplements, pre-workout, or if they're trying to meet some new PR or just not listening to their body's cues. So I don't think it's necessarily fair to call out CrossFit necessarily, but it has been the subject of attention with rhabdo. Fall football, why more than later in the season? I think that it's probably obvious, but I will just say that these are often deconditioned athletes who are coming off of not participating in something. A lot of these kids start in spring or even early summer. They're already doing workouts. So I think, at least in my area, this isn't really their starting point in the fall. But certainly hot weather, there may be dehydration. They start putting pads and helmets on, and all of a sudden they're getting really hot, dehydrated, and the coach is trying to send a message with, "We are going to work hard." And you often see cases of rhabdo in those teams. Ultramarathon, I think, probably speaks for itself, why there's a concern. This is a concept that you will find in the news if you are looking for it. You will see clusters of cases of rhabdo periodically, particularly in the late summer or early fall, when you have coaches implementing heavy workouts for their athletes, and you will see clusters of these athletes that will be hospitalized with exertional rhabdo, and coaches get into trouble after that. So, okay, what is rhabdo? So this is the definition. Rhabdo is skeletal muscle breakdown. It's pathologic, and it results from physical exertion, not traumatic. There is, in fact, the majority of cases of rhabdomyolysis are traumatic. This is non-traumatic variety that we're talking about tonight, and often occurs in association with heat illness. And there's lots of risk factors. We're going to talk about those in a minute. But necessarily, this middle bullet point is key. It manifests with both clinical and laboratory findings, not one or the other. Okay. I'm going to foot stomp that later even more. Other causes of rhabdo we see in trauma, crush injuries in particular, system trauma, people who've been in motor vehicle accidents. So also sepsis, you can see rhabdo. So if you're on an inpatient unit, CK is worth checking in your septic patients. Cardiac arrest often leads to rhabdo for different reasons: seizures, surgeries, electrocution, and et cetera. There's lots of different causes of an elevated CK with muscle breakdown, which does meet criteria for rhabdo, just not exertional rhabdo. Typically, rhabdo could be considered just the effects of exercise gone too far. It could be just a reckless coach. It could be an overmotivated athlete. Or it could be a good coach and a good athlete on a bad day. And we'll talk about some of those reasons. But local symptoms that you're going to see include muscle soreness. You could even potentially develop muscular hematomas. There can be secondary resulting in muscle fascia fibrosis, or even heterotopic ossification later on. Occasionally, these can be life and limb threatening. So compartment syndrome, cardiac dysrhythmias, acute kidney injury, or DIC are all potential complications of rhabdomyolysis. And for those reasons, we need to maintain a high index of suspicion and treat them as if they may be going in that direction. So we need to be on our toes with this. Most of the time they will not, but you don't want to be caught on your heels if an athlete is kind of going downhill, and it can happen fast, in particular in athletes with sickle cell trait. So that is another key take-home point that I want you to remember is if you have these types of symptoms and a concern clinically for an athlete with rhabdo and they have sickle cell trait, you need to be in fast mode. You need to be on high alert and get that patient to the ER quickly if they're not already there. So why me? Why today? This could be just simply a good athlete, a good coach on a bad day. Some of these extrinsic factors are probably obvious. Certain medications are worth noting. Statins, I think we all know that. These can cause muscle injury. Antipsychotics, mostly the older ones. A lot of people don't take them anymore, but olanzapine comes to mind. Stimulants, caffeine, potentially some of your ADHD medications might potentially increase your risk. But I think primarily we're talking about pre-workout supplements. Caffeine, some of these pre-workouts have just ludicrous doses of caffeine, and nobody should be taking that, in my opinion, but people do. Heat and humidity definitely increase your risk because it puts the muscle cell membrane just at increased susceptibility to breakdown. It also increases your risk for heat illness, and heat illness and rhabdo often go hand in hand. A leadership culture of winning at all costs is often found to be a very significant contributor. I think we can all probably envision that. None of us really want to work with that coach or that team who is just kind of brutal over the top and really not interested in medical feedback. I think that those types of coaches are fewer and fewer, but they're still out there. Probably more at the high school level, but I can recall a case or two at the D1 university level where there was a culture of winning at all costs, and it led to athlete harm. Okay, intrinsic conditions, viral illness, especially, think of COVID. This is still out there. We don't test for it probably as much as we were a few years ago, but that can increase the risk for muscle, myositis, and that could increase your risk for exertional rhabdo. Dehydration, heat illness. We talked a little bit about sickle cell trait. We'll talk more about that later, and a few other conditions of glycogen storage diseases or lipid metabolism that can cause metabolic myopathies and increase your risk for ruptured muscle cell membranes. So deconditioning or high motivation in an athlete are also risk factors, things to be aware of. All right. I think that this is perhaps one of the most valuable slides, and I think our medical system does not do a good job at educating doctors or allied, providers, including PAs, NPs, paramedics. People aren't familiar with what is rhabdo and what is not rhabdo. So there's some dogma out there. I'm going to try to break that for you. Delayed onset muscle soreness is not rhabdo. It is normal to have that. I think we're all familiar, right? We're in sports medicine, that muscle soreness that comes after a workout, and that does not meet criteria for rhabdo. There may be elevations in muscle enzymes, including CK, but if they're just within the mild to moderate symptom category, this is not rhabdomyolysis and should not be labeled as such. It should not be diagnosed as that in the medical record. In the military, that can end someone's career. A diagnosis of rhabdo, even if done inappropriately, can get somebody discharged from the military. So we need to try to correct that. And a similar term, but there may be some overlap, but maybe not, is hyper-CKemia, which is obviously an elevated CK value, but without the symptoms of rhabdo. So you could have somebody with DOMS and hyper-CKemia, or you could have somebody with simple hyper-CKemia and completely asymptomatic. Low to moderate intensity, even little bits of exercise can result in CK elevations in the blood, and has no clinical consequence and does not need to cause alarm. Personally, I think that just the way that CK values come out, they're in the hundreds, and that's, it sounds high because, it's 1,000, it sounds high, but we're used to seeing numbers in the 1.2, or, other labs that we deal with are often in the lower range. So don't let that trip you up. Don't be alarmed at just the order of magnitude. We'll talk about what is significant a little bit more later. But okay, so rhabdomyolysis is by definition myonecrosis that is symptomatic, and it is caused by overexertion, not other causes. So what's happening at the cellular level, I think this histologic image on the left is useful. You can see normal skeletal muscle on top and, myonecrosis on histology in the lower image. what happens is you get acute, and it's usually on top of chronic or cumulative muscle overload. It's muscles that are already fatigued from days of workout before, and then you dump a big load of exercise on a certain day, and that puts it over the top. You get local tissue hypoxia, and you can read down the list: the reliance on anaerobic glycolysis, depletion of intracellular ATP, and thereafter the sodium potassium pumps and the calcium pumps then fail. At that point, the cells start to develop, you know, intracellular overload of calcium, metabolic acidosis, sarcolemma permeability, and death of the myocyte. So what then continues to happen is then you have all of these osmotic molecules, including proteins and electrolytes, that have spewed into the extracellular fluid that draws fluid out of the capillaries, and you start to get swelling, which increases pressure in the compartments and can lead to compartment syndrome. So myonecrosis is identified typically through lab tests. There's multiple, intracellular contents that are dumped, and many of these have been investigated as potential for biomarkers. There are two in particular that have drawn attention, but note on this list, LDH and AST are intracellular proteins within muscle. And they're also, but we think of them as liver, right? A lot of times. So when you check somebody with a complete metabolic panel who you suspect has rhabdo, and you find an elevated AST or LDH, that is almost certainly just muscle contents, not liver injury that you're seeing in those blood results. We're going to focus on myoglobin and creatine kinase for a few minutes. I want to teach you a little bit about what these are and what they're good for when you test for. So let's start with myoglobin. Okay, myoglobin is part of the contractile unit of the muscle. It actually binds oxygen, and that is what delivers the oxygen to the actin and myosin chains, which then actually pull and cause contraction of the muscle unit. So the myoglobin, similar to hemoglobin, it is an iron-containing protein that binds oxygen. It has a high affinity for oxygen, pulls oxygen out of the blood. When over 100 grams of muscle tissue is injured, that is typically enough to exceed the plasma binding capacity of myoglobin in the serum, and you will start to develop overflow of myoglobin into the kidneys. And if there is enough of it, you will start to see it, because similar to hemoglobin, myoglobin is a pigmented molecule. It'll be dark and typically cola-colored urine. The trouble is that myoglobin, if there's enough of it, will start to condense or sludge in the kidney tubules, and that causes back pressure, and it impairs the kidney's ability to filter and process blood through the glomeruli. So myoglobin in the blood has a half-life of just a few hours. So it typically peaks about 3 hours after exercise and returns to baseline before the day's over. It's very, what we would say, evanescent. It's there and it's gone before you really have much of a chance to do anything about it. So because of that, most patients presenting to the clinic with rhabdo 24 to 72 hours later, when they develop symptoms, their myoglobin's already gone. It's already back to normal or close to normal. Additionally, it typically takes a laboratory well over 24 hours to get these lab results processed. So it's not very useful as a biomarker if you need to know today if this athlete does have muscle injury. So there is a role for checking myoglobin, particularly urine myoglobin, but we'll talk about that more. Let's talk about creatine kinase. This is an enzyme that's found in many tissues. It's very dense in muscle. It's also found in brain. There's certain different subtypes which are found in the brain or in the heart. So there's actually you can fractionate creatine kinase into different forms. So that's where you get like CKMB in your cardiac enzyme panel. That's a myocardial, a form that's more specific to myocardial tissue. Within the skeletal muscle, you just do an unfractionated creatine kinase. So what you're getting is all of the CK, and you're not specifying which type it is. Any tissue that's processing a lot of ATP is going to have a lot of creatine kinase. So it's abundant in skeletal muscle, cardiac muscle, and brain. This biomarker, this enzyme peaks in about 24 to 48 hours after exercise. So now we're on to something that means this is going to coincide much better with the clinical syndrome of rhabdomyolysis when patients are showing up in the lab, and it's much slower to drop. The half-life is about every 48 hours. So in other words, it drops by about 50% every 48 hours after it reaches its peak. It's not exactly linear, and sometimes there can be bumps and stuff, but that's a pretty good trend. So a little bit more information on CK. There is controversy around the cut point or the threshold to make a diagnosis of rhabdo, because any number that we assign is going to be somewhat arbitrary. Furthermore, there is a lot of variation among individuals on what is their normal CK value. It will vary by age. The older we get, beyond, about age 18, it's going to go down as our muscle mass goes down. It varies by race, varies by gender, it varies by body size, even excluding or controlling for other factors. Muscle mass, body size, or medical history are going to be determinants of our normal CK value. A laboratory's upper limit of normal is defined by each lab. So I can't tell you what it is because you have to ask your own laboratory what they define in their assay as normal. But typically it's about 200. So 5 times that upper limit of normal is the most widely accepted threshold for diagnosis of rhabdo in association with the clinical signs and symptoms of severe muscle pain, stiffness, tenderness. This is a very highly sensitive level, but it has low specificity just because it's easy to get above 5 times the upper limit of normal. Some experts have proposed a higher 10 times or 50 times the upper limit of normal as a threshold, but that has not gained traction. I favor, and we favor in the military, a low threshold just so that we are not missing people. It's safer. And so keep in mind, African-American males have double the normal CK value of Caucasian males. Similarly, African-American females have 1.5 times the normal CK value as Caucasian females. Some people have a resting CK with no exercise at all that is in the 600 to 700 range. And this is their normal. And that's not a problem. That's already starting to push that 5 times the upper limit of normal, which is about 1,000. Okay. So just a real quick thought here. In D1 college football, on day 7 of preseason practice, average CK is 1,500. That in and of itself is enough to diagnose rhabdo. But again, if without symptoms, that is not rhabdo. We see a similar thing in Army basic training, and more on that here. Notice that in this table on the left, we see a range on day 7 of asymptomatic Army basic trainees, and this is a sample of 499 trainees, up to 35,000 on that CK value. 0 of these people had any symptoms. None of them required treatment, but we see people with CK up to that level. And 26% of these people had a CK that was over 5 times the upper limit of normal. Bear that, now compare that with this box on the right, an athlete who has recurrent episodes of severe muscle pain or stiffness, cola-colored urine, AKI, who have had inpatient treatment. They may not reach those high levels of CK. It may be in the lower range, but they still have, that is rhabdo with symptoms. It's not just the CK value that defines it. Okay, CK is not a perfect biomarker. If you draw a CK before 24 hours after exercise, you may be not seeing the peak yet. So you may falsely reassure yourself. Keep in mind that different muscles have a different level of creatine kinase. So the diaphragm is actually quite low. Rectus abdominis and probably most of our working skeletal muscles have a much higher concentration of CK, but it's not the same in every muscle. And it is believed that unruptured cells may expel creatine kinase as a preventive mechanism to prevent apoptosis. So CK into the blood may not necessarily represent, in all cases, muscle injury. I just want to throw you out some caveats. When you really dive into the science here, it also does depend on plasma glutathione concentration. So it's not as simple as we might like to think it is, but an elevated CK is our best biomarker, and it is what we should use to diagnose. And we do monitor healing with it, although it is not exactly accurate. Okay, so again, this is probably the number one take home. In the setting of exercise, an athlete with severe muscle pain, stiffness, and or weakness, severe, that's not mild, not moderate. It has to be like enough to make them limp, or like their elbows are going to be stiff, or shoulders, they can hardly raise them up. And a CK at least 5 times the upper limit of normal, that is enough to make a diagnosis of exertional rhabdo. I want to talk for a few minutes about the athlete who shows up to you with dark or discolored urine. I want to present to you a differential diagnosis, things that you should be thinking of. Number one, I hope that rhabdo pops right into your head, because it is one of the more common causes among our athletes of a discolored urine, but there's a lot of other things. So for you to be aware of, on a rare occasion, exercise-induced hemolysis or exercise-induced hematuria can cause frank, blood or hemoglobin in the urine. So that will cause discoloration, something to be aware of. It's not necessarily rhabdo every time there's, dark or the dipstick is positive for blood. I've seen a case where an athlete just drank tons and tons of fruit punch and they were peeing red. So it's just the red food coloring. So it's good to, ask those questions. I think you've all seen those kinds of athletes who, just love their sugary drinks and they don't really care. So foods, beets, blackberries, rhubarb can do it. We talked about food coloring. Medications can do it. I'm sure you're familiar with phenazopyridine, rifampin. There's other medications, including a couple of antibiotics that can do it. Metronidazole is a common one that can discolor the urine. Renal disease, ureter bladder disease, anything that's going to cause blood in the urine, we need to be thinking about these things in our athletes. The key is rhabdo will have a UA that's positive for blood on the dipstick, but there will be no RBCs on microscopy. So I have put this little diagram together. This is not evidence-based, but I hope that this helps you think through a good algorithm. You've got an athlete with dark urine. You need to get that UA. You need to spin the urine with centrifuge, and you need to get it looked at under a microscope. Doesn't need to be you. It needs to be somebody in the lab, probably. If you want to do it, great. So you need to look at the sediment at the bottom of the tube, if there is any. You need to look at the supernatant after you've spun it, which is the liquid that's on top. If that liquid on top is dark or red, you go to the left on this algorithm. Typically, there would not be any significant sediment here. This is the type of athlete who you want to suspect for hemoglobinuria or myoglobinuria. This is probably rhabdo, more likely than anything if it's an athlete. You're going to test that urine for myoglobin and recommend that you repeat a serum CK. If there wasn't already an elevated CK in the blood, you need to check it again in 12 to 24 hours. So if their UA is negative for blood, but they have a dark supernatant, then you need to be thinking about these foods, medications, you can read the slide, or rarely porphyria. if there is a dark sediment, now you're going to the right on this algorithm. And I've given you some guidelines on what types of things you're looking for. If there's intact RBCs, you're looking for post-renal. So in something in the urologic system is bleeding. If there's RBC casts, we're going to be thinking about glomerular bleeding, like post-streptococcal glomerulonephritis. White cell casts, we may be thinking of something like AIN, acute interstitial nephritis. Granular or other types of casts, you might think of necrosis in the kidney, like an acute tubular necrosis, which often seen in as a toxicity to medications or multiple other causes. That's a topic for another day, but I just wanted to kind of get your mind thinking on things that you might need to think with an athlete with dark urine. Okay, we're going to start going through an algorithm. This you can find in those papers that I've referenced earlier. And I would encourage you to have this available as a reference in your files or wherever you need to turn when you have clinical questions. So it starts with, at the top, with an athlete who has a recent history of exercise and is presenting to you either with severe muscle pain or with dark urine. So the first question we ask ourselves is there a primary exertional heat illness? You may be on the sideline of a sporting event, and you need to ask yourself that question first, because this can be more imminently life-threatening. And you're going to manage that if you do suspect heat illness. You're going to check a rectal temperature and treat accordingly. If they don't have a primary heat illness, you're going to do a history and exam, and you're going to get some labs, including a CK, a UA, and a CMP. The primary diagnostic decision point here is the CK. And if it is above the 5 times the upper limit of normal, now you have enough information to diagnose rhabdo, so you're going to the right. If that CK is not elevated to that level, you're going to look at the UA and see, is it positive for blood without RBCs? And if that is true, then you're dealing with either myoglobin in the urine or hemoglobin in the urine, one of the two. And then you're going to proceed accordingly. If that is myoglobin in the urine, you need to treat it as rhabdo. You're going to give them activity restrictions. You're going to repeat the CK and check that myoglobin in the urine. Once you're going to get that repeat CK back probably before you get the myoglobin in the urine test back. And so that's where you're going to diagnose rhabdo, and then we're going to make additional decisions. So once we have a diagnosis of rhabdomyolysis, now we need to ask ourselves, what are we going to do? Are we going to admit the patient for inpatient treatment, or are we going to treat them as an outpatient? And that decision point hinges on these key factors of high risk for adverse outcomes. And so if any of these 7 in this box on the right here that's highlighted in red, if they have a CK over 20,000, if they have any concern clinically for compartment syndrome, if there's any elevated creatinine or acute kidney injury, dark urine or confirmed myoglobinuria, if they have metabolic or an electrolyte abnormality like an acidosis or a elevated potassium or phosphate, we'll talk more about that. If they have sickle cell trait, they've bought themselves an admission, you will admit that patient. I recommend that you admit that patient because those are high-risk patients. If they have limited follow-up, you are better safe than sorry to just admit them and take care of them and monitor them as they get through the acute phase and are safer to then follow up later. So better safe than sorry. Okay, so let's look at this case. This is a 21-year-old male, has a multiracial background. He's comes to you 24 hours after a 3-day soccer tournament. He's been playing at a high level, very competitively, and he's complaining of severe muscle pain in his thighs, and he's walking stiff. He does not bend his knees normally, and so you can tell he's apprehensive of walking, and he's a little stiff getting down, sitting in the chair. So you're already on high alert. Obviously, this talk is about rhabdo, but his urine is yellow. He denies any discoloration of the urine. He's never had this type of symptoms in the past. You start asking about his family history because being astute, you know that there are some things that run in families that may increase his risk for a complicated case of rhabdo. He denies any personal or family history of heat illness, denies any history of rhabdo or muscle problems, and he denies anyone having any complications with anesthesia in the past. So if you're astute, what we're going at with that is any malignant hyperthermia susceptibility, which often manifests when they're exposed to halothane anesthetics. Okay, so you do an exam. He's got a normal neuro exam, but his quads are very tender to palpation. On his laboratory results, everything's normal except his CK is 15,000. So this goes back to that first quiz question that I showed you. And this is basically a very similar case. He's got severe muscle symptoms. He does have a CK that's over 5 times the upper limit of normal. So is this rhabdo? Yes, it is. I think we're all clear on that now. Do you treat this guy as an inpatient or as an outpatient? So the question there, again, comes, let's go backwards, goes down to this high-risk markers. His CK is less than 20,000. We do not suspect compartment syndrome based on what we're currently seeing. He's not, you know, pain out of proportion. He's not having pulselessness or pallor or and let's just say, so we already, I showed you that his sickle cell trait is negative. All of his labs were normal other than the CK. And let's just say he has good patient follow-up as an outpatient. He's reliable. We have good access. So we're going to see him back tomorrow for a follow-up. This is somebody that you can treat as an outpatient. But if there are any of these high-risk markers, you are going to, I recommend that you admit them to the hospital, whether the ICU or the inpatient ward. Outpatient treatment hinges on generous oral hydration. How much fluid? You don't want to overhydrate and end up with another problem, potentially hyponatremia or something else. So you're going to recommend like 4 to 5 liters per 24-hour period, a liter every 3 to 4 hours while they're awake. So they need to be pumping the fluids, you know, and I'd give them or make sure that they have a water bottle of a known volume and that they can monitor that and commit to that because they really need to be taking in a lot of fluids and peeing clear. They need to be obviously limited from physical activity. They're not going to practice. They can sit on the bench perhaps, but they're not going on the field. They are shut down. And they're having frequent follow-up every 24 to 72 hours. Erring on the shorter side early on, you can start to lengthen that out as they get better. You're going to repeat labs each time they come back. It's going to be frequent lab draws. They just need to know that that's just going to be how it is for a little bit. Inpatient management, I don't want to belabor on this because I think we're getting low on time. So I'm going to let you refer to the paper. You can glance back through the slides. You can freeze the lecture when you get to this slide and read through it. You're going to be monitoring for complications. You're going to get a bunch of stuff on admission. You're going to get a bunch of labs, including coags. You're going to get an ABG. Recommend you get a lactate. In addition to all the other labs we've talked about, to make sure you have a phosphate level. That's very important. Phosphate tends to go high in patients with rhabdo, especially if they're going to have a complicated case. So elevated phosphate is one that you need to worry about, and you need to probably talk to your either your intensivist or a nephrologist and make sure that you're on top of that elevated phosphate level because that can cause a thing called acute phosphate nephropathy. So, all right, we're going to move right on past this because I want to talk to you about a few other things. You're going to be monitoring for metabolic acidosis. If they are starting to get acidotic with a serum pH less than 7.3, you probably need to start running some bicarb in the IV fluids. And if you read the paper, there's guidelines on that. Just 2 amps of bicarb in a liter of D5 water. Run that parallel with your other fluids like a lactated ringers for a total IV rate of about 200 milliliters per hour. And that should do you well. If you're alkalinizing the urine, then you may want to consider getting an intensivist or transferring to the ICU. Okay. You should know that the risk of mortality is low in cases of exertional rhabdo, with one exception, and that is if they have sickle cell trait. They actually have a significant risk of mortality, and their rhabdomyolysis seen in conjunction with sickle cell trait associated collapse is often explosive. It comes on very fast, and it can be fulminant, and they can get severe hyperkalemia. They can get arrhythmias, and they really can pass away. So Dr. Eichner, in one of his papers, says that outside of heat illness or sickle cell trait, mortality is basically zero. And he has never seen a case. He's never found a case. And I think that's something we can lean on, that essentially mortality does not happen outside of sickle cell trait or exertional heat stroke. And those are the cases of rhabdo in conjunction with those other things that we can be in really deep water pretty quickly. Sickle cell trait, I think you're all familiar with when this reaches that heroic level of exertion, very intense physical exercise, you can get exertional sickling, and this can lead to a conscious collapse, a fulminant, severe rhabdo, and these people are at high risk of death. People with sickle cell trait are outside of ECAST. Sickle cell trait does increase the risk for rhabdomyolysis, but as long as there are universal training precautions, including regular work rest cycles, so regular breaks, good hydration, and monitoring for the heat and ambient conditions, there is no risk of mortality, and that's from a randomized controlled trial done in the Army. So there's no safe discharge CK level. As long as it's going down, the patient is improving, creatinine is normalized, or it has a definite trend toward normalize. You can discharge these patients and just keep having them hydrate orally. You do want to make sure that after you stop the IV fluids, that you keep them in the inpatient side for at least half a day or more while you make sure that their CK doesn't bump once you stop the IV fluids. Okay. So there's an excellent paper out there. Again, Dr. O'Connor, Dr. Asplund put this excellent paper together in Sports Health a few years ago. Has great guidelines for return to play. We'll go over that a little bit more in a second. There are high risk markers for recurrence. You need to be aware of these, and probably the most important ones are exertional rhabdo after a low to moderate workload, or a peak CK that reached over 100,000. You'll see other markers here if their creatinine kinase just stayed high and just very for over 1,000 for 2 weeks despite resting, etc. These are athletes that we want to set aside, and they may be unique. They may actually have an underlying muscle disorder like a myopathy, and they may need further testing to identify what is that. So I think we're getting low on time here. So again, I'll refer you to the paper to read more on this. But if an athlete shows up to you with cola-colored urine, they have myoglobinuria when you test it, and it was a low to moderate workload, you should be on alert for in primarily two main muscle disorders. They're the least rare, which is McArdle's disease or a myophosphorylase deficiency or a CPT2 deficiency. And there's advanced testing that can be ordered. A lot of times they need an EMG at least 3 weeks after the injury. You got to wait, or send them to a neurologist in particular who has neuromuscular subspecialty training can be very helpful. Okay, so here's a graded return to play protocol, and an athlete needs to pass through each of these 4 phases before they can be safely returned to play at a full intensity. Phase 1, I would just highlight in particular, this is very light, supervised exercise. It's indoor. There's no resistance training, and you're getting labs. This is 3 days that they're doing this type of exercise, and you're going to get labs at the end of that 3 days. And they have to have a CK that's below 5 times the upper limit of normal in order to move on to phase 2. And here we're going to start increasing their resistance. We're going to give them a week to exercise at this level, ideally supervised by an ATC or a PT. And then you're going to check their labs again. And assuming that they keep tolerating these levels of exertion without bumps in their labs and without recurrence of symptoms, then you can keep advancing them until they're fully returned to sport. And it should take, close to 3 to 4 weeks at least to return somebody back to sport. It's not going to be a fast RTP. Okay, so we're going to wrap up here. Take home points. Rhabdo is a clinical syndrome, is defined by severe muscle symptoms and laboratory evidence of myonecrosis. A CK over 5 times the upper limit of normal, or about 1,000, is the most widely accepted. CK elevation without muscle symptoms is not rhabdo. Low-risk patients can be managed as outpatients. High risk, in particular your sickle cell trait patients, should be treated as inpatients, and they should be given aggressive IV fluids and close monitoring. You're watching electrolytes, kidney function, acid base, they're watching for metabolic acidosis. And then safe return to play starts with making sure that they're not at high risk of recurrence. And there's algorithms that you can follow to identify those with rare muscle disorders, or perhaps malignant hyperthermia susceptibility is that other one. So dark urine after low to moderate workload should raise your concern. And here's some references. We'll park it there. Happy to take any questions if we have any.
Great. Thank you very much, Nate. That was fantastic. That was a great overview for everybody, and hit on some really great teaching points. So if you have questions, please type them in the chat. We do have time for a few questions. So one of the questions that was asked was kind of talking about asking about return to play, which you kind of went over. But one of their questions was, in your experience, how long does it typically take for the CK to kind of return to normal in these athletes?
Yeah, so it does depend on how high it went, because again, the half-life of CK is about 48 hours. So you're going to typically take for a mild elevation, if your CK was about, let's say it was 5,000, after about 48 hours, you're going to expect it to be about 2,500. 48 hours later, it's going to be about 1,000, 1,200, 48 hours later. So you're looking at in the 1 to 2 week range. And then that person is going to then have to go through a return to play protocol, which takes a few weeks to safely go through and make sure that their CK is not bumping up again. And it is important to do that gradually and not just if they had the symptoms. And if you made a proper diagnosis of rhabdo, you need to be careful with these people. I worry about the people. Well, that's the wrong word. I see in my practice that people are often misdiagnosed as rhabdo when in fact they had DOMS with hyperCKemia. And in those patients, we can actually correctly educate the patient that they did not have rhabdo, but instead they had a benign muscle, a normal physiologic response to exercise with an elevated CK. And you can let them go back as soon as they feel able. There's no reason to hold them out. So that's a good, you may get referrals as a sports medicine specialist. You may get referrals of patients from primary care or the ER who have a diagnosis of rhabdo. And so I would challenge you to look at that and not just take that as face value, but to say, does this athlete really have rhabdo? Or was this a misdiagnosis. And more often than not, I don't know, I see that commonly. And don't treat them as you don't need to just be handcuffed by somebody else's diagnosis that they labeled them with rhabdo. You are a doctor, and I would encourage you to re-educate those patients, and perhaps you get an opportunity to talk to those providers who are overdiagnosing rhabdo and perhaps point them in the right direction, cordially and kindly. Yeah, but if they have a severe elevation of CK over 100,000, it's going to take a while for that to trend back down. The body's got to process that. It may take a few weeks for that CK to downtrend. You don't need to keep checking it every 24 to 72 hours. Once you get them out of the inpatient, realm and they're stable, you can start checking that CK, once a week, and just following up with them every 1 to 2 weeks and until you get it back down to normal. They're shut down, and so they should be hydrating and following up with you. Once you get them all their labs normalized, then you can start considering return to play as long as they're asymptomatic.
Yeah, I think that's always the important point is sometimes for our fellows, like, to understand that just because they have a diagnosis, like, you'll see a lot of people that come out of the hospital or the ER with diagnosis that are not, because they just don't have the experience in sports medicine. They're not used to seeing high CK levels. But I mean, if you take fall football, summer 2-a-day workouts, like, every single one of those guys have probably 2-3 times CK levels if you check all of them. And so you get an athlete that maybe had like exertional cramping and ended up going to the ER for IV fluids, and then they check a CK, and then they're like, oh my God, they have rhabdo. And then you really have to tease that out, because like we've talked about, if you're treating a true case of rhabdo, I mean, you're talking a minimum of probably 4 weeks to return to play, and usually on the realm of like 3 months. So, like, it could be even 6 months, depending on how severe it is. And so, you're really putting these athletes down for a long time with this diagnosis. So it's really important to make sure that that's the correct diagnosis. And also, I think the other important point you made is timing. Rhabdo occurs quickly after exercise. People don't present 3 and 4 days later, and those people that present like 3-4 days later it's really DOMS, and DOMS can be very, very dramatic. I mean, I'm sure you have as well seen people that can't, after doing a heavy chest tricep workout, can't straighten their elbow out 3 days later, can't even, so I mean, it can be very, very dramatic. So I think that's important distinction. I think we have time for one more question, and there is one more question. I think it's kind of a very interesting one. They asked that in combat sports where you see repetitive trauma to the muscle, have you seen that be enough to cause rhabdo in an athlete?
I have not seen it. I don't deal with a lot of like UFC or boxing or combat sports. So there is a fair amount of that goes on in certain communities within the military. I have not been heavily involved with some of those communities, but so I'm going to say the answer is no. However, I can imagine that it, I don't know. I'm going to say I don't think that's really going to do it. The repetitive direct impact, that's what I'm thinking of. That's the difference. Now, there's a lot of exertion, right? And with UFC, that's a very, physically demanding sport just from a cardio, respiratory standpoint. They're working hard. And so I guess it's possible that an athlete, especially someone who has underlying risk factors, might have rhabdo in the setting of a combat sport. But barring risk factors and barring just that exertion load, I don't really think of like the direct muscle trauma as being enough to cause rhabdo. James, do you see it differently?
I've never really seen it. I mean, certainly you can see people that get like a localized myositis, from, trauma. I mean, we see it a lot in quad contusions where you get like a more diffuse myositis than just like but I've never seen it cause rhabdo before. Now I'm not familiar if there's any case reports in the literature or not.
Yeah, that's an interesting question. It certainly can be caused by trauma. So I wonder if that's where this question was coming from. Is in the ER, it's typically there's a lot more cases of traumatic rhabdo than there are of exertional rhabdo, and that's certainly true. But this is high energy trauma and crush injuries and motor vehicles involved and stuff. So that's where we're talking about causing traumatic rhabdo, not necessarily combat sports.
And I think also important, always to remember that there are other things that cause elevated CK in our athletes, viruses, things like that. So again,
Mm-hmm.
always something to keep in the back of the mind when you're thinking about your differential.
Yeah, myositis.
So if there are no other questions, I really want to thank Dr. Nye for this. This was great. Really, really great, useful information. And then encourage you to follow up on our next week's lecture. And then, like we kind of put up on the at the beginning, if you have suggestions for topics, please let us know. We're always looking for topics that you guys find interesting and want to hear about. Have a great night,
Good
everyone.
stuff.
Thank you for joining us.
Thanks, everyone. Have a good night.